All right, today we're jumping right into one of the most intense and, honestly, high-stakes fields in all of medicine, emergency psychiatry. This is the absolute front line, where clinicians are dealing with acute crises of the mind, and every single decision can change a life. It's a world that really demands speed, precision, and just a profound amount of empathy. So, what actually happens in a psychiatric emergency? Let's find out. Okay, let's start with the textbook definition, just so we're all on the same page. A psychiatric emergency is a sudden, severe disturbance that needs immediate intervention. Now, we're not just talking about feeling down or having a bit of anxiety here. This is a real crisis that can totally impair a person's ability to function or even put them or others at serious risk. This is the clinical starting point for everything we're about to get into. A psychiatric emergency isn't just one single thing. It can be the first really scary appearance of a new illness, or maybe a relapse of a condition someone's been managing for years. It could even be a direct result of a physical medical problem. Sometimes it's an overwhelming reaction to stress, a bad side effect from medication, or a crisis tied to alcohol or drugs. It's this sheer variety that makes the field so incredibly challenging.
So, how in the world do professionals navigate what looks like total chaos? Well, while it might seem unpredictable from the outside, there's actually a remarkably calm and structured process at work. Let's break down the step-by-step approach clinicians use to bring some order to a crisis.
The entire response is really built on these three pillars. First, they do a super fast but thorough history, often piecing together the story from the patient and anyone who's with them. Second, and this is absolutely critical, they do a physical and neurological exam. Why? Well, because things like a brain tumor, a serious infection, or a head injury can all show up looking like a psychiatric issue. You have to rule out the physical stuff first. And finally, there's the mental status exam, which directly checks out the person's thinking, their mood, and any immediate risk. Okay, now we're going to turn to what is often seen as the model for all psychiatric emergencies. And sadly, it's the most common and lethal one, suicide risk. This is an area that requires just incredible care and immediate, focused attention. This statistic is, well, it's incredibly sobering. Between 2 and 10% of people who attempt suicide will tragically die by suicide within the next 10 years. That just shows you what a powerful predictor any attempt is. It really highlights why follow-up care isn't just a good idea, it's absolutely essential. An attempt is a huge warning sign that the underlying pain is severe, and it is not going away on its own. The language we use here really matters, so it's important to get these clinical distinctions right. Completed suicide is the term for a fatal outcome, and attempted suicide is when the outcome is non-fatal. Then there's a suicidal gesture, which is a bit different. The person might not have had a clear intention to die, but the act itself is still a major sign of distress, and tragically, it can still end in an accidental death. Now this right here, this is a big one. This slide busts a common and incredibly dangerous myth. The idea that someone talking about suicide is just looking for attention and isn't a real risk is completely false. The clinical evidence couldn't be clearer. The vast majority, almost 80% of people who die by suicide give warnings beforehand. Every threat, every mention has to be taken seriously, period. So, what are the practical, life-saving steps that get taken? Well, it always starts with taking every single threat seriously. That's followed by a proper risk assessment. And, so important, removing any means of self-harm from the person's environment. Close observation is key in the short term, but the real goal, the long-term goal, is to treat the root cause, that underlying condition like depression or psychosis that's fueling the suicidal thoughts in the first place. All right, let's shift gears now to a condition that's maybe less understood by the public, but is just as life-threatening. This is when a person seems to just shut down completely. We're diving into the world of stupor and catatonia. Stupor is such a fascinating and, frankly, frightening state. A person in a stupor can't move or speak, but, and this is the part that's so wild, they're often still completely aware of what's happening around them. They are, in a very real sense, trapped inside a body that won't respond. This is a true medical emergency. And catatonia, which often goes hand in hand with stupor, comes with a whole range of really striking symptoms. It's not just about freezing in place. It can mean actively resisting any attempt to be moved, or holding these bizarre postures for hours on end, or even automatically mimicking the speech and movements of people around them. These signs give clinicians a clear vocabulary to describe this profound state.
So, a huge first step in treatment is figuring out the why.
Is it organic, meaning it's caused by a physical illness like a stroke or an infection? Or is it psychogenic, which means it's coming from a primary psychiatric condition? This table shows some of the key clues clinicians look for. For instance, a psychogenic stupor is way more likely to pop up right after a major life stressor. So we've gone from one extreme, a state of complete shutdown, and now we're going to pivot to the total opposite, a state of extreme agitation, excitement, or even violence. This is another really common emergency that is often feared and honestly deeply misunderstood. Man, the diagnostic challenge here is just immense. This extreme agitation can be caused by almost anything, from dementia to a manic episode, a seizure, or drug withdrawal. A clinician's first job is basically detective work. Figure out what's driving the behavior before you can even think about how to safely and effectively treat it. Now, this is so important. The goal here is about care, not control. The management follows a clear escalating ladder. The first and most important step, the bottom rung, is always verbal de-escalation, using a calm, firm, and reassuring voice. Only if that fails do you move up to considering medication. In physical restraint, that is the absolute last resort, only used to prevent immediate harm to the patient or others, and always for the shortest time possible. You know, when you boil it all down, everything we've talked about today comes back to this. The goal of emergency psychiatry is really twofold. First, it's about making sure everyone is safe and stabilizing that immediate crisis. And second, it's about creating a genuine human connection that can act as a bridge from that moment of crisis to the long-term treatment and support that person needs. And all of the framework we've used for understanding these critical situations comes from an amazing clinical guide, a short textbook of psychiatry 7th edition by Neeraj Ahuja. So we'll leave you with this last thought to chew on. We've talked a lot about clinical protocols and diagnoses, but at the heart of every single one of these emergencies is a human being in profound distress. So the real question is this: when that crisis is met not with fear or with judgment, but with structured clinical understanding, what truly changes for that person?